Hello, so this is Fundamentals of Case Management Practice, Skills for Human Services, 5th edition, Chapter 18, the Mental Status Examination. How to observe. Throughout the interview, note how the person communicates verbally and non-verbally. Look at the content of the communication. Look at what the person tells you. Look at how the person tells it. Look at how friendly, comparative, guided, or listless the person seems. What to observe. General appearance. Observe how well clients take care of themselves, their hygiene and dress. Look at physical characteristics. Note posture and gait, attitude and personal style. Note hostility or warmth, whether the person is demanding or passive, playful or withdrawn. Behavior or psychomotor activity. Observe posture and mannerisms and motor activity. Note tremors. Speech and language. Look at how the person speaks. Is it pressured, emotional, improvised? Does the person make up words? Watch for various things such as inability to understand or produce language, trouble experiencing thoughts, or fluent, bizarre, nonsensical speech. What to observe. Emotions. Mood. Notice clients' moods. Are they happy, anxious, euphoric, sad, affect? Watch for the underlying flow of moods. Are they appropriate, blunted, withdrawn, excited? Neurovegetative signs of depression. In major depressive, body functioning often becomes irregular. Listen for complaints about falling asleep, staying awake, weight loss or gain, constipation or loss of appetite. What to observe. Cognitive functioning. Orientation and level of consciousness. Observe anything from a coma to just lethargic. Ask clients if they know who they are, where they are, and the date. Attention and concentration. Can the person remain focused during the interview? Can the person concentrate on one thing for an extended period of time? Memory. Note head injuries, difficulty with shortness in long-term memory, and anesthesia. What to observe. Cognitive functioning 2. Ability to abstract and generalize. Can clients take a proverb and explain its abstract meaning, or are they concrete and literal? Can they see similarities and differences? Information and intelligence. Do clients know information known by the general public? Be sensitive to culture and education. Example, how does the person define the proverb, a stitch in time saves 9? Does the person know who the president is? What to observe. Thought and perception. Disordered perceptions. Look for hallucinations, a sensory perception in the absence of external stimuli, or illusions, a misinterpretation of actual external stimuli, being estranged from self or the environment. Thought content. Note how clients think. Have they distorted a portion of reality or delusion? An inappropriate idea for which the person cannot be dissuaded using normal arguments or evidence. Thought processes. Watch how clients think. Look at things such as racing thoughts, spontaneity, illogical ideas, incoherent speech, or flight of ideas. What to observe. Suicidality, homicidality, and impulse control. You have a clinical and a legal obligation to assess whether the person is in danger to themselves or others. Notice the client's history shows impulsivity. Listen for thoughts regarding suicide or homicide. Does the client have thoughts? Is the client actually making plans? Does the client have a plan all developed, including the means and the timetable? If the client has a fully developed plan and the means to carry it out in the situation is more serious, take all thoughts or expressions of suicide or homicide seriously and explore these with the client. What to observe. Insight and judgment. Insight. Check to see if the clients understand they have problems and the role they themselves might play in those problems. Can a client describe their ideas as to why they are having these problems? Judgment. Note if clients are able to critically evaluate their situations and make good decisions about the best course of action to take. What to observe. Reliability. Accuracy of the client's report. State briefly your impressions of client's reliability and accuracy and giving you the details of their situation. If clients have distortions, such as delusions or hallucinations, the information they give is likely to be unreliable. Or to observe the environment. Making note of the sudden surroundings in which the person lives. Does furniture block the doors? Are there strange wires, odd decorations, or window coverings? Be careful not to mistake poverty for an inappropriate environment. Be sure what you are seeing is really a manifestation of mental illness and not some other reason for keeping things that way. Note how the person keeps the home. Are there unusual collections of trash, spoiled food, clutter, or unwashed dishes? Is there urine or feces in the home and neglected pets? Clinical definitions. Confuse. We often use this word to mean a person is unsure about a decision to make. Better to say the person is uncertain, ambivalent, or unsure. Confuse is used clinically to describe someone who is not oriented to time, person, or place. Obsess. We often use this word to mean the person is focused on one thing to the exclusion of mostly everything else. Better to use the word preservations. Obsess is used clinically to describe a person with persistent, unwanted, and intrusive thoughts that appear to haunt the person. So that's all I have for this video. Thank you for watching.